he uses mother first.
What's good to get all this to work.
Didn't get to use mine.
You remember anything from last lecture?
Yeah.
Some?
Yeah.
Okay. The first content when we have the orientation, beginning into med math, generally people's heads swell because of all the information, and I have to be careful that they don't explode in the middle of the class. But then generally after this first little bit, things settle down, and then we start looking at body systems and so forth. We focus a little bit more rather than just shotgunning everything. So if you've gotten so far, hang in there. It'll get a little bit easier. At the same time, it'll get a little bit harder because you'll have to understand pathophysiology and anatomy of various organ systems. But we'll be going over those as we go. Pardon? Absolutely.
Yeah, a little bit. Just palette.
We talked about half-life had come up a couple of times in the last lecture. People had talked about half-life and medication and so forth. What does half-life mean? Okay. How long in your body is a generalization, but that's close. Yes. How long it say that again? Right, the amount of medication takes is a grade of 50%. We have your peak, okay? So a half-life of a medication determines how often that medication is given. You have some medication, half-life is like 36 hours. So how often you're going to be giving it? You're not going to be giving it on more than once a day. Yes, sir.
Is it 50% effectiveness or 50% serum?
Both. Well, while you still have medication on board, you still have both of those going on. You can still have 50% of the medication on board and still stay within the therapeutic level. So basically what you had said, the time it takes, 1/2 of the original amount of drug in the body to be removed. For it to be used within the body or to be excreted and or excreted. Along with half-life, we have onset, peak, duration. Onset we talked about last time. The rate of onset depends on route and drug properties. For example, if you're giving a IV medication, the onset is what? Immediate, right? Because it goes right into the bloodstream, right to its target organ. And if you have a tablet, it's a little bit slower, 20 to 30 minutes for it to take effect. Okay? Then we talk about onset is how fast does it actually get in and start working. Even look at peak. Peak performance is the elimination rate equals the absorption rate. It's again we're looking at when your peak of medication. We're looking at it is within therapeutic range that it has to be effective. We have the you have two levels. We'll be going over those as we go along. You have a therapeutic range, and then you have a below range, and then you have a dangerous range. Ideally, all medication that you're given are within that therapeutic range. Now, how do they determine that? How do they determine what medication therapeutic range is? Well, in a regular basis, you would say, you would find out symptomology and so forth and say, yeah, it is working or it is not working. But how do we know to give that amount of medication to begin with?
Look it up.
I like that. Look it up. Okay. When I worked pediatrics, I used to have a Harriet Lane book in my pocket. Harriet Lane was a pink book, and that had everything that had anything to do with pediatrics, from diagnosing to lab levels to medications and everything else. I used to think, oh, these doctors are really smart because they're able to just pull the stuff off the top of their head. No, while they're sitting at the desk, they're sitting around doing this. They got to look that up too. What happens is when the medication is being developed is that they do their experiments on people, on animals, and so forth. When we go into side effects in that, you look at a medication and it has 3 benefits and 87 side effects. And we'll talk about that, meaning that the benefit outweighs the side effects. When we get into cancer drugs and that, you'll see that that's very important. The benefit outweighs the side effects. But also what happens is that when they do the testing, they will get their laboratory rat or mouse or whatever it is, and they will give that creature up to 500% of what they consider to be the recommended dose for that medication, so that they can see every single symptom that might occur with that medication. So in your medication books, you'll look at that and you'll have all these side effects. Well, the first 2 side effects are the ones that are, the first one's the one that's seen all the time. The next one's seen less often and less often and less often and less often. And how they get a medication, with the onset and peak and so forth, that's what they do the same thing. They give it to animals first for testing, and then they get human test subjects and they'll do the same thing. And find out, does it work appropriately and how much should be enough, based on their symptoms. Duration of time is the duration of the therapeutic effect. How long that is. For example, you take penicillin. Penicillin is good for a total of, well, therapeutically, about 3.5 to 4 hours. Depending on the medication itself, depending on the person and the age as well. There's other issues that come into effect. So most antibiotics are given every 4 to 6 hours. Some are given every 8 hours because of how potent they are. And that's how long the duration is. Some medications won't last very long, and therefore the duration is short, and then the repeat of medication has to be faster. For other medication, duration is longer. For example, you give a medication called digoxin, which is an antiarrhythmic to keep your heart beating on a regular basis. Its duration is 24 hours. Half-life right around 26, 27 hours. But about 24 hours is when it's effective. And then it has to be repeated in order to keep the therapeutic level up. We talk about duration as well. We look back at antibiotics. The doctor says, oh, you got a sore throat, you got to have some antibiotics. So, okay, well, I'm going to give you 10 days worth. And you take your 3 days, you feel better, you put the rest in the medicine cabinet just in case. You can use them later on, you do not have to buy anymore. You guys are laughing because you do that, right? I know that. It's but the duration of medication has 2 different things in here. One is how long it's effective, and the medication has to be used, like antibiotics, has to be used for a specific period of time to maintain that therapeutic level in order to wipe out whatever bacteria or that which is invading the body. And we'll be going over that when we're going to anti-infectives and those. You'll see that it takes more than just a couple of doses to get rid of whatever bug it is within the body. Elimination sites, we talked about those already. What do you remember?
Sweating,
Kidney,
kidney, urine.
lungs, sweat, saliva. Somebody had said breast milk yesterday. Absolutely, there it is. Skin, intestines. So it's treated where if anything can come out of the body, that's how the drugs get out of the body. We have pharmacodynamics, a study of drug mechanisms that produce biochemical or physiological changes in the body. And that's why we're giving the medication. We're trying to create a change, hopefully a better change. What the problem is, you're trying to bring the body back into a homeostasis. For example, again, we have digoxin and antiarrhythmics. So the heart's not beating effectively enough. It can't maintain a beat. It's not beating very well. We give the medication that brings it back in line where now it's firing the way it should be. It brought the body back into homeostasis or equilibrium. And the medications that we're giving, that's what we're trying to do, is to bring the person back into that state. So biochemical, a cellular process. I used to think that the way medications worked, if you took like 14 or 15 medications, what happened is you swallowed them. When they got into your stomach, you had a little guy with this red and orange sign. Stop, go, and medications had to go to the left or to the right, or to the, and then he directed them however they needed to go in order so they didn't get mixed up. You don't want the red pill to go to the yellow organ because they needed to go to the red organ for the yellow. But the action happens at a cellular level when the medication, like we talked about last time, we have receptor sites on the cells that the chemical within that medication is geared toward. And we'll talk more about that as we go along. So this biochemical process is at the cellular level. What is the physiological effect? Okay, how it affects the body? Physiological or physically, right? How it affects the body. You have a infection, you give it a medication, it gets rid of the bacteria that was there, brings the body, and the body responds with all the symptoms of ickiness and all that stuff go away, and the person goes back to normal. Again, once the drug is at the stop action, it can modify the rate, increase or decrease at which the cells or tissues function. And sometimes that's a expected effect, and sometimes it's a secondary effect. For example, someone's in pain, they're given morphine. Okay, morphine blocks the pain receptors. We'll talk about that when we get into pain. But what it does to the tissue, especially smooth muscle, it tends to slow it down. And that's why when you're taking narcotics, you tend to get constipated. Because your bowels are smooth muscle, and it tends to slow down what's called peristalsis. Remember peristalsis? Mm-hmm. You know, the area in the stomach? That slows it down. And a light came on in some guy's head, and they went, oh, if that's the case, why don't we devise a medication that has narcotics in it to slow this down? Every person has diarrhea. And they developed a medication called Lamotrigine. It's a narcotic base, or pseudo-narcotic base in order to have the same reaction. So it affects the cells, it affects the cells that it's targeting as well as others. You talk about cancer medication, if you look at the chemotherapy affects the fastest growing cells in the body. Cancer cells are the fastest growing cells in the body. But we have other faster growing cells, don't we? We have epithelial cells, we have hair, we have those things as well, and guess what? The chemotherapy affects those because they're fast growing as well. And that's why you hear it falls out, the nausea, vomiting, and diarrhea when you're taking chemotherapy. For the same reason, it affects the cellular level either positively or negatively based on what's going on. Does that make sense?
Mm-hmm.
So you cannot take a drug and turn it into a magic potion and make the cell or the body do what it's not supposed to do. It will only make the cells increase or decrease in their function. It won't change their function. Agonist, not to be confused with an antagonist. An agonist stimulates. We'll look at some of those drugs. You have a drug that is given, and you give an agonist, so it enhances the medication, so you get a better response. An antagonist is something that blocks, so it prevents that drug from working. A really good example is we have a medication called Coumadin, which is an anticoagulant, or better known as a blood thinner. An antagonist is vitamin K, which causes clotting. Non-specific and non-selective. We have drugs that are made for a specific action, but they not only affect the receptor sites of that organ, they affect the receptor sites of other organs as well. So you can have a medication, you're taking it, and you have other side effects associated with that. Your antibiotics is a good example of this, non-specific. It does attack the bacteria, but it also affects other parts of the body and gives you things like nausea, vomiting, and so forth. Not to be confused with killing good bacteria versus bad bacteria. They have the example here of urocholine, which increased bladder tone. We'll talk about that during urination. But one of the things it also does is decrease the heart rate. So it's non-selective. It'll attack or affect more than one organ. If you want to look at an example, is you have medications that are, you have receptor sites on the cell, and the chemicals within that medication match these receptor sites so that it attaches to the cell and causes the cell to either slow down or to speed up its action.
Does that go back to what you said before, where it's not going to make a cell do something that it wasn't performed to do?
Correct. It won't turn you into a bunny. You know, when you take the pink pill, you're a bunny. You take a blue pill, you're an ogre. That won't happen. Or you're like Fiona. Shrek. You know, it doesn't happen that way.
So it'll just kind of bypass that cell if it's not going to work.
Correct. Exactly. Now, when we talk about non-specific, non-selective, that medication may affect it. I mean, it may not, attach itself fully, but it still will affect that as it is going for the receptor sites that it's trying to capture. So you have some of that side stuff going on.
Will both of those agonists still attach, or will one of them?
Well, the agonist will attach, but what happens is that it attaches and it enhances the medication that is being used. You look at this and you think, okay, the agonist comes on, therefore it's going to block and then the medication is not going to work. What happens is the agonist attaches, the medication comes in, attaches to the agonist, and then zips right into the cell. It kind of opens the door for you so it can go right on in. Does that make sense? So it enhances the medication itself. It'll attach and it speeds up the action of the medication that's already there, or that is coming in. When an antagonist comes in and blocks the sites and does not let the medication hit that site. Does that make sense? You got I think I got it, but I'm not sure. Look on your face. I'm talking to you.
Yeah, I got it.
Okay, you got it. You got it.
Oh, I'm good too.
Oh, yeah, you just want to make sure. It's I gear what I'm teaching by a lot of my facial expressions. And if I see a facial expression, it's kind of like, okay, well, it isn't there. Then I tend to just hope. I don't want to bypass anything. So good, thank you. And not specific, again, as it's going to a specific organ, it affects other organs or cells along the way. And as we go into specific medication, you'll see how that works. And how it affects other organs in what we call side effects, because the medication itself is non-specific. Does that make sense? Okay. And then non-selective, basically what it does is that it will attach itself to any receptor site on any organ and cause some kind of response. Even though it is geared for that one, it may be geared for the heart, non-selective means it's still going to attach here, it's going to attach here, it's going to attach here. At the same time, most of it's here, but it'll attach otherwhere where a non-specific kind of bits and pieces come off and get scattered here and there. Where non-selective, parts of the medication actually attach to the cells of the organ itself. Very similar. Very similar.
Yeah.
We'll see this when we look at respiratory and cardio and blood pressure medications, how they affect. You have a medication for blood pressure and how it affects all these organs at the same time. We talked about side effects, not related to desired drug effect. Side effects are not supposed to be there, but in a lot of medications, they are there. A wonderful side effect of antibiotics is diarrhea. That's a side effect. And that's caused by non-select or non-specific? Nope, it's specific. It really is. It's attacking bacteria. But you have good bacteria in your body, okay, that helps the absorption of food. You have E. coli when it's in an exact amount, so it's helping with the digestion. But what happens is you give antibiotics that kills the bad bacteria as well as the good bacteria, and now you have diarrhea. Because it's not allowing the body to absorb what's going on. Okay? Adverse reaction or undesired effects, these are serious. A side effect is uncomfortable. An adverse reaction can be life-threatening. Not necessarily, but it generally is serious. Another good example for adverse reaction would be antibiotics again. You're given antibiotics, you feel the bacteria. The adverse reaction is that your body cannot tolerate it. And the adverse reaction is anaphylactic shock. That's an adverse reaction, it's a life-threatening reaction. And we go through all the different medications. You skim through the book and you see the blue and the orange boxes and so forth. You look at the side effects and adverse reactions. You look at those and you'll see that one is okay stuff that happens and one is stuff that happens. You have to be aware of. Drug interactions. You have one drug that interacts with another drug. Hope I don't mess you up too bad. That interferes with another drug. We'll be seeing examples of that as we go along as well. Toxic effect. What does that mean?
Toxic.
It's going to kill you. Yeah, that's a good way to put it. Too much. Too much. And we saw last time with the failure of elimination or metabolizing of the medication, we can get toxic effect. And sometimes toxic effect is nothing more than, okay, something serious is going to happen, but it's not yet. I had a lady, her name was Minnie Faulhaber. I can say that because she's dead now. She was 102 when I had her as a home health patient. And she was laying in her bed and so tired. And she had a pulse rate of about 56 and she was tired. Usually when you're in bed, your pulse rate can go down. It's not an issue. But she wasn't her usual charming, jolly self. So I called the physician. I think I called him and said, I think we have a digoxin toxicity going on here. Can I take her off her medication? And he said, what are you worried about? She's as old as dirt.
Ooh.
Doc, okay, do whatever you want. Took her off all her medication and then put them back on one by one. And then that took away her digitalis toxicity. So she was no longer sleeping, had a low heart rate and lack of energy. So she would back up in her wheelchair, sitting by her front window, waving at people as they walked by. This was in a town called Wausau, Wisconsin. She was a little girl when that was found. And everybody, at least one time during the week, would make a point of walking by her house and waving at Minnie as they went on their day. They would go out of their way for miles to stop and wave at Minnie as they go on. So when she was in the window, they were upset. And people were coming to the door and knocking down something. Well, she lived to be 104. She did pretty good. But to prevent toxic effects, we monitor blood levels. There are, we talk about peak and trough and so forth. We can do that with medication like lithium, which is used for a psychotropic medication. We do that for some antibiotics that are very strong and toxic. We'll talk about them, gentamicin, vancomycin, and how you need to maintain that therapeutic range is so small that you have to keep a close eye on it. All that says is half-life of lethal dose divided by the half-life of the therapeutic dose equals the toxic index. Draw two lines. The upper line, if you go above that, you're at the lethal dose. You go below that, you're below the therapeutic dose. So it's not doing any good. It's like having a really, really bad headache and taking jelly beans because they taste better than aspirin. And the therapeutic range is in between those two lines, and the therapeutic dosage of medication keeps you within that range, which puts your